Even before Neratinib came, right? I mean, Neratinib is still not approved, but even before we knew about Neratinib, I never liked Neratinib and capecitabine. Why? Because it always has been the least of my options for patients, because it is very toxic and patients have hard time tolerating it because of diarrhea. It's easy to manage, nausea is easy to manage, and fatigue is easy to manage, but I think diarrhea has a maximum impact on the quality of life. Right, so I think that had always made me to stay away from Neratinib. But if a patient has CNS disease and I need something which crosses blood-brain barrier, I have to use it. And when I have used Neratinib and capecitabine combination, I always start with this low dose. I always start with the antidiarrheal agents, and I'm very conscious about it because my nurse is calling the patients every week to make sure how they're doing, because sometimes patient doesn't know and they're so dehydrated, they don't go to the hospital. Sometimes I just have the patients come into my clinic every week for intravenous fluids, right? I do that all the time, and then I'm very we are asking the patients about the diarrhea, and if it doesn't get better with with the antidiarrheal agents, we add something extra like cholesterol or other agents.